Good morning to all the chairpersons, the moderators. Thank you for having me. So today I'll be talking about a bespoke algorithm for the reconstruction of contracted sockets. So we all know what a contracted socket is and what it entails. Basically, there is some loss of phonacial space, volume, surface, which sort of leads to the inability to retain a prosthesis. However, the classical grading which has been present until now, the classical Gopal Krishna classification, quantifies only the phonesis. So we decided to come up with some algorithm which can sort of unify all the conditions associated with a contracted socket and possibly decide how to manage a contracted socket better. So the aim of our study was to compare the predictive ability of the Gopal Krishna grade 1 to 5 classification versus our bespoke algorithm in the outcome of contracted socket management. So we conducted a retrospective study on our group of 47 patients who underwent socket reconstruction. So our anatomic factor classification, we called it FSV. This is based on shallow phonesis, a surface deficit, and a volume deficit. So inadvertently, whenever we see these factors, we tend to use them while planning surgery. But until now, there is no gross algorithm yet in place to manage them well. So when there is a shallow phonics, we do phonics deepening sutures. When there is a surface deficit, we do mucous membrane grafting. When there's a volume deficit, we can do a secondary implant. And when there are combined defects, we do a dermis fat graft. So we decided to check the outcome measures as the retention of prosthesis or the need for a repeat surgery. So we had nearly twice the number of males as females. The causes for socket contraction were surgery, trauma, chemical injury, and congenital. So as per the conventional classification, this was the grading. The maximum number of patients were in grade 2 and 3. And in the results, the indication for surgery was not retaining prosthesis, a small prosthesis, and a tilting prosthesis. Now, based on our anatomic factors, when we classified the patients, all the patients had a shallow phonics. So all of them underwent surgery for that. And 60% had a volume deficit and 40% had a surface deficit. So isolated FDS or phonics deepening suture was done for patients who had shallow phonics. In addition to that, when there was a surface deficit, a mucous membrane graft was performed. If there was a volume deficit with phonics, then a secondary implant in FDS. And if all three, a dermis fat graft in FDS. The mean follow-up was around 18 months. So in the post-surgery events, most of them did well. Some had a granuloma, others skin excoriation, infection, and 8 of them needed repeat surgery. In the surgical outcome, 4 of the patients had a tilted prosthesis or not retained prosthesis, which we took as a bad outcome. So this is an example of a patient with one factor. So phonics forming sutures were done for the phonics, shallow phonics. This is 2 factors. So there was a shallow phonics and a volume deficit. So a secondary implant and phonics formation was done, after which the patient retained the prosthesis well. And in this, there was a phonics surface and volume deficit, for which a phonics forming suture and a dermis fat graft was done, after which the patient was able to put in a prosthesis. So in the results, the repeat surgery as such didn't show any pattern, because either we didn't have enough numbers or there was some sort of bias towards using the anatomic classification. But with respect to the bad outcomes, the conventional classification did not predict the bad outcome well, wherein higher grades of contracted socket were showing a less of a bad outcome. Whereas in ours, patients who had more than 3 factors from the anatomic classification had a bad outcome, 21% versus 3%. So to conclude, with a good planning, the FSV, that is phonics, surface, and volume classification, even worse sockets get a good result as a better socket with surgery. Almost 90% of the patients were able to retain a well-fitted prosthesis using the FSV algorithm. Our bespoke algorithm helps to predict a poor outcome with respect to the number of anatomic factors as compared to the conventional method. And with respect to the repeat surgeries, further studies are needed to quantify the difference. So what we know already is that phonacial shallowing is not the only factor which correlates with surgical outcome. What we added is surface deficit and volume deficit. And we need future studies to quantify it better. Thank you.
Well, thank you, Dr. Rwituja, for a nice presentation and good paper. One question: why are you calling it bespoke classification?
Because till now there are only case reports or sort of studies which are done in patients wherein they found one factor and then decided to work on that. For example, surface, they would probably do an AMG or an MMG and then work on it. But until now, there isn't a proper classification with a large number of patients to sort of, decide exactly what to do. Because till now, people are only saying, oh, they have 2 shallow phonesis or 3 shallow phonesis, 4 shallow phonesis. So until now, there is no unified classification on how to go about these cases in a standardized manner.
And the other thing is that your 3 grades are fine, but I think there is an importance of 1 fornix shallow or 2 shallow fornix on the management itself, because if only there is shallowing of lower fornix as it is there in standard grading, then we can do directly the fornix formation. If there are more than 1 fornix which are shallow, then we may have to resort to MMG. So it does have some implication on the management part. So it would have been, I think, better if you would have sub-classified your FSV. Then I think it would have made more management orientation clear. But even then, it is nice attempt.
Yeah. In future, that
you have mentioned about the volume deficit, right?
Yes. Yes.
So what about that in your study?
So deficit with a shallow phonics, they underwent a secondary implant. And those who had surface deficit along with volume deficit with a shallow phonics, they underwent a dermis fat graft, which would account for the surface creation as well as to augment the volume, sir.
Anybody, any question?
So I think
Dr. Ruchi, Dr. Suva.
I think we can go to the next talk. It's a nice presentation. I think the concept was always there in our minds, and you have just brought it into, and we really need to get a new classification. I agree with you totally.
Thank you, ma'am.